Hi, good evening. Can somebody from the organizers confirm if Dr. Shweta is there online?
Good evening, sir.
And yeah, and when shall we start?
Good evening, sir. Am I audible?
Yes, this is Dr. Shweta. I think it'll be good if you keep your
One second.
cams open. Yeah, and all I see is that everything says NNF faculty. I won't be able to make out who is who here.
Good evening, sir.
Hi, Dr. Shweta. I think we'll just wait for Dr. Vijay to join. Dr. Vijay, are you there? I think he must be. Dr. Vijay?
Hi, sir. Good evening, sir.
Yeah, hi, Dr. Vijay. If things are fine, can we start?
Yes, sir.
All right. Yes, Dr. Shweta, you can start with your presentation. You can share your slides.
Okay, sir.
Yes, 1 second. Dr. Shweta, Dr. Vijay seems to have not joined yet. I'm talking about the faculty. We'll just wait for a moment.
Okay, sir.
Good evening, Prashant, sir. I'm Dr. Vijay. I have joined, sir. We can, I think, we are already late by 10 minutes. We can start with class, sir.
Yeah, that's great. Thanks. Start, Dr. Shweta, please.
Okay, sir. Good evening, everyone. I'm Dr. Shweta Tiwari from Cloud9 Hospital, Jayanagar, and I'll be starting today's presentation. I'm presenting a case of a baby born to 30-year-old primary mother with non-consanguineous marriage, spontaneous conception, gestation 28 plus 1 week, with birth weight of 1.2 kg, delivered by LSCS, and date of examination is 15 September with corrected gestation age of 34 plus 6 week and weight of 2.34 kg. Coming to antenatal history, first trimester, baby born to primary mother by spontaneous conception, booked pregnancy at Cloud9 Hospital. Mother started on folic acid supplementation, no history of fever or rash, no history of drug intake or radiation exposure, no history of hypertension or diabetes. Coming to second trimester, mother took iron and calcium supplementation, no history of fever, burning micturition, bleeding or spotting PV, no history of gestational hypertension. Anomaly scan done at 20 weeks were normal, and Doppler done last at 28 weeks of gestation was normal with normal liger. Mother presented at 28 weeks with pre-labor preterm rupture of membranes. Mother was admitted to hospital and started on steroid. 2 doses of betnosol were given 24 hours apart. Last dose mother received 4 hours prior to the delivery. MGSO4 loading dose was given, followed by maintenance dose for 12 hours. Total duration of PPROM was 18 hours. Female baby was born by emergency LSCS in view of preterm labor with fetal distress on 30th July at 11:18 a.m. with birth weight of 1.2 kg. Baby cried immediately after birth. APGAR scores were 7 and 9 at 1 and 5 minutes respectively. Baby was received in plastic wrap. Baby was found to have respiratory distress with Silverman-Anderson score of 6 by 10 And baby was started on delivery room CPAP with PEEP of 6 and FiO2 of 40%. Vitamin K injection was given, and baby was shifted to NICU in incubator with CPAP. Coming to NICU course, respiratory system.
Can we interrupt and
Yes, sir.
just go into some insights
Yes,
in
sir.
your antenatal and postnatal history? Um, so, if this was a baby who has come and got admitted, and the parents have been told to get antenatal counseling from you before this
Yes,
delivery,
yes, sir.
what all would you concentrate on, Dr. Shweta?
Sir,
So,
first of all,
because you said there was some time for us to give antenatal steroids as well, isn't it?
yes, yes, sir.
Yes.
Uh, Sir, first of all, I would like to know the history before talking to the parents. I like to know the gestation, antenatal Dopplers and ultrasound that were available to us. And then for counseling, I would like to explain to the parents. First, I'll introduce myself, and then I'll make them feel comfortable, and will discuss with them the expected course and the expected delivery at 28 weeks. The parent should be explained about the mortality and morbidity associated with it, and what is the survival rate in our institute, that will be explained to them. And along with that, the benefits of giving antenatal steroids, antenatal magnesium sulfate, will also be explained to them. The expected course of stay and the expected cost of stay will be explained. Along with that, sir, risk of respiratory distress syndrome, need for interventions like intubation, respiratory support, need for ventilation, and need for IV fluid, of feed intolerance, NEC, uh, and risk of IVH and long-term neurodevelopment outcome will also be explained to them, sir.
All right. So, anything else other than this medical things you want to tell the parents, which they also would be a part of?
Sir, developmentally, like involvement of parents in the NICU, in the baby care, that will be on the later part of the NICU stay, will also be explained to them. And
Do you want it to happen in the later part of NICU or right from the time of birth?
sir, from the birth also
Yes,
we should
absolutely.
be
So,
involving parents.
family-centered care is something which you are going to emphasize,
Yes,
and
sir.
probably a note on kangaroo mother care, early initiation of kangaroo mother care, and
Yes, sir.
also mother's milk, right?
Yes, sir. Early
Okay.
initiation feeding.
Yeah, good. So I think the points were well covered. I have another question. So you said this mother received betnisol. Can you
Yes,
tell
sir.
me about antenatal steroids? What is recommended by Government of India?
Sir, Government of India recommends dexamethasone because it is easily available and cost effective. It is recommended at 4 doses, 6 mg, 12 hours apart, to be given
Yeah,
in case of any expected delivery between 24 to 34 weeks in next 7 days, sir.
wonderful. I think that's a great answer. So let's say you're giving betamethasone, like in your case.
Yes.
So what would be the advantages?
Sir, betamethasone, actually, if it has a short course, like in 20, we have to give 2 doses 24 hours apart. But sir, betamethasone, if it has two mixture of two preparation, acetate and phosphate, that is better than the single preparation which is available in India, that is phosphate.
Yeah. So in your case, how would you have given betamethasone to match the recommendations? So you said you gave 2 doses 24 hours apart, right?
Yes, sir.
Yeah. So how would you probably dose it for the available, I mean, with the available betamethasone we have in India?
Sir, sorry, I didn't get the question.
So we don't have betamethasone acetate and
Yes, sir.
acetate phosphate, right?
Yes, sir.
But if you're using betamethasone instead of dexamethasone, how will your dosing be?
Sir, betamethasone we give 12 mg 24 hours apart. 2 doses only are required to be given.
What's the difference between the ones which has been studied in worldwide versus the one which is available
That
now?
is the combination of
Yes,
SAP.
so we are not using that, right?
Yes, sir.
So how will your dosage change? All right, so please go back about it. So if at all you're using betamethasone, you have
Yes,
to
sir.
give like how you're giving dexamethasone. So the intervals will be the same, dose will be the same, and
Okay.
there might not be so much of advantage of giving betamethasone here. All right.
Yes, sir.
Yeah, that was the point I was trying to make.
Okay, sir.
All right. So you said the baby was, mother was also given magnesium sulfate.
Yes, sir.
Can you explain why it was done?
Sir, magnesium sulfate is recommended for all expected preterm deliveries less than 32 weeks old. If delivery is expected in next 24 hours, it helps in neuroprotection.
So when you talk about neuroprotection, specifically what we are looking at, would you have an idea?
Sir, later on neurodevelopment outcomes at 2 years.
Specifically?
Sir, it
All right.
reduces the risk of cerebral palsy.
Yes. Okay. All right. Good. So
Dr. Shweta, I have one question. You
Yes,
said
sir.
that in the delivery room you had started with CPAP of 6 and 40% FiO2.
Yes, sir.
So and you did do an X-ray also,
Yes,
chest
sir.
X-ray. Then, so what are the indications of early surfactant?
Sir, in a preterm delivery, if a preterm baby is having respiratory distress at birth and requiring FiO2 of more than 30% at adequate PEEP, then it is the indication to give surfactant.
So we could have avoided X-ray in this baby, right?
Yes, sir. We can give like X-ray is not
So
mandatory.
giving surfactant will decision. So based on PEEP requirement as well as FiO2 requirement.
Yes, sir.
Okay. Okay. And what are the advantages of antenatal steroids?
Sir, antenatal steroids, first of all, it reduces the risk of respiratory distress syndrome. Need for need It reduces the duration of respiratory support and need for ventilation. Also reduces the risk of intraventricular hemorrhage and NEC and improved neurodevelopment outcome.
Okay. You can continue.
Yes, sir. So coming to NICU course in
just a quick point here. I think when these kind of questions are asked, so
yes, sir.
you might have to have two answers ready for yours. Okay, one is evidence based. What does your
Yes.
Cochrane say? Specifically, 4 to 5 things, and
Hmm.
what other physiological benefits you have. Okay, so be very precise and don't be very generic in your answers, especially antenatal steroids and things. Okay,
Yes, sir. Sure, sir.
all right.
Uh, Coming to respiratory system, after shifting to NICU, baby was connected to CPAP support with nasal prongs with PEEP of 6 and FiO2 of 40%. Chest X-ray showed low volume lung with reticulogranular pattern. Surfactant Curosurf was given 2.5 ml per kg by insured method at 1 hour of life. Post surfactant, baby was reconnected to CPAP with a PEEP of 6 and FiO2 of 25%. Loading and maintenance dose of caffeine was given. Baby was weaned to HHFNC on day 3 of life and to room air by day 8 of life. Caffeine was stopped at 34 weeks of corrected gestation age.
Yeah, so can we go into a little bit of depth here?
Yes, sir.
So suppose a baby is born in your, I mean, this baby is born born and you're attending the delivery. Tell us what all you will look at in terms of giving good respiratory therapy for this baby, in the sense that what would be your golden hour management with regards to respiratory system in this baby right from the time of delivery? So what would be an ideal situation?
Uh, Sir,
Ideal things which you would want to be done for any baby.
only respect to respiratory system, you're asking, sir?
Respiratory system. So let's look at respiratory system and then we'll go to the other system because you're looking at respiratory system here. From the time
Okay,
of
sir.
delivery, what all ideally you would want to do for a preterm baby with distress?
Sir, if a preterm baby, if baby has cried immediately after birth, we'll do delayed cord clamping and then we'll take the baby and assess the baby. If respiratory distress is present, we'll start with the delivery room CPAP. Immediately, we'll start with delivery room CPAP with the PEEP of 5 to 6 and we'll titre the FiO2 along according to the target saturation. During resuscitation, we can use up from 21 to 30% of FiO2 in less than 35 weeks gestation. And then early selective rescue surfactant should be given if the FiO2 requirement is more than 30%.
So how do you define early rescue surfactant, or how do you explain rescue surfactant?
If surfactant is given within 2 hours of birth, then it is early rescue surfactant, sir.
Can we give surfactant in delivery room? Anyways, we have
Yes,
to give
sir.
surfactant for this
Yes,
baby.
sir. If the criteria are met, we can give, sir.
Okay, so what would be the criteria to give surfactant?
Sir, with adequate PEEP of at least adequate PEEP of 6 and still the FiO2 requirement to maintain the target saturation of 91 to 95% is more than 30%, sir.
All right. So maybe we won't jump to give surfactant right in the delivery room. Maybe we'll have to wait for the baby to settle, because we know that CPAP is also a effective modality to decrease respiratory distress syndrome.
Yes,
Okay. Yeah.
yes.
So what's the dose of surfactant you have given here?
Sir, sir, Curosurf we have given, that is 2.5 ml per kg or 200 mg per kg is
Of
given.
what? 200 mg per kg of what?
Uh,
It's always good to use generic names. That was a comment here. Okay, so Curacao, yes, probably it would be better in examinations you use more generic terminologies. All right.
yes, sir.
All right. Okay. So can you tell us the different modes of installing surfactant into the lungs?
Yes, sir. Sir, one method is insure technique, in which we intubate, give surfactant, and later extubate the baby to CPAP. And the other method can be less invasive LISA, invasive surfactant administration, and MIST is minimally invasive surfactant administration. So,
Okay, so which one would you prefer?
sir, minimally invasive is preferred because in that we don't have to like intubate the baby. We can continue the CPAP, and there is the better distribution of surfactant and better recruitment of alveoli.
Yeah. So you said Lisa and Miss. So is there any difference between them?
Sir, in LISA we use forceps to insert NG tube, and in MIST we insert Meagles, sorry, angiocath we insert without using the forceps.
So I don't think there's any difference as far I have known. So Vijay can correct me. Lisa and Mist are the same, where you use a thin catheter, right? So whether how you introduce with use of Magil forceps, it depends on the way you intubate the baby, right?
Okay,
Yes,
sir.
but point well taken that when you give surfactant, it ensures that the PEEP is delivered so that there is advantage. So can you tell us the advantage so of giving surfactant through a Lisa versus insure technique?
Sir,
What does your
according
evidence say?
Sir, according to studies, the LISA and MIST have shown less need for respiratory support and intubation, and even neurodevelopment outcome was better with these methods.
The developmental outcome may not be the stock answer for all the questions, So I was looking at bronchopulmonary dysplasia. Okay.
Yes.
Yes, less the duration of invasive ventilation and thereby decrease bronchopulmonary dysplasia. All right. Yeah, I think that's a good. So, Dr. Vijay, you have any questions regarding this respiratory care?
So, Dr. Shweta, you said that you had received the baby in plastic wrap.
Yes, sir.
So, when will you remove it?
Sir, usually we once we shift the baby to NICU and we ensure that the baby's temperature is well under limits, then we remove
Like
and put the baby into.
36.5, right?
Sorry, sir.
When the baby's temperature has reached 36.5,
Yes, sir.
then at that time you'll remove the plastic wrap.
Yes, sir. After shifting to NICU.
Yes, yes.
Yes, sir.
Okay. Continue.
Should I go ahead, sir?
Continue.
Cardiovascular system, baby was hemodynamically stable throughout the hospital stay. Sepsis part, baby was started with prophylactic antibiotics on admission. Sepsis screen sent was normal and blood culture showed no growth, so antibiotics were stopped after 48 hours.
So,
Yes, sir.
sorry, what is prophylactic antibiotics? Can you define it?
Sir, not prophylactic, but if we are suspecting, we have a strong clinical suspicion, then we can start the baby on antibiotics.
So, what was the risk factor in this baby to start antibiotics?
In this baby, there was a spontaneous preterm labor with premature rupture of membrane for 18 hours and respiratory distress at birth.
So, don't call it as prophylactic antibiotics. Now, you suspected sepsis. In view of that, you had started antibiotics, and since blood culture was negative, you stopped it.
Yes, sir. Yes, sir. Then central nervous
Yeah,
system.
so as Dr. Vijay rightly said, reinforcing, there's nothing like prophylactic. There's no prophylactic antibiotic. There is something called empiric antibiotic. Okay. So there's no antibiotic which prevents infection.
Right, sir.
Yeah. All right. So just since you're moving forward, we talked about temperature of 36.5. Can you tell us how does this temperature, especially the admission temperature of a baby, monitoring it will help in this baby, and also probably ensuring normothermia would help in this baby.
Sir, like drop in temperature has been associated with increased risk of mortality. 1% drop in temperature increases the mortality by 28%. That's why it is important to monitor the temperature, and it should be all throughout the transfer within the range only, sir.
Good, wonderful. Continue, please.
Next, central nervous system. Baby's cry tone activity was good. There was no neurological deficit, and neurosonogram were done on day 1, day 3, day 8, and day 28 of life, which were normal. Baby was initially kept under incubator care, and kangaroo mother care was started on day 5 of life. Coming to nutrition, baby was initially started with minimal enteral nutrition with the expressed breast milk, which was mother's own milk, at 10 ml per kg per day. UVC was secured at day 1 of life and TPN was started. Feeds were gradually increased as per unit protocol. TPN was stopped once baby reached feed of 100 ml per kg per day. Baby reached full OG feeds by day 4 of life. Direct breastfeed and suck feeds were established by day 46 of life. Currently, baby is on full suck feeds at 180 ml per kg per day EBM with full HMF fortification with supplements.
Can I just get back to the previous slide? Yes, Dr. Vijay, go ahead.
No, sir. You ask, please, first.
Yeah, I was just wondering why KMC has been put under thermoregulation. So could it have been put in another heading?
Yes, sir. Developmentally supportive care.
Okay. So with that, can you please tell me what are the advantages of KMC?
Sir, first advantage is it helps in temperature regulation. Other is it promotes early breastfeeding in the baby. It has been shown to reduce the incidence of apnea also. And it improves milk output in mother, and KMC has been associated with more in rates of exclusive breastfeeding at discharge. And there has been reduced incidence of sepsis also for the babies who were initiated on KMC early.
Yeah, good. So again, here, so this probably is a stock question for all of you who are attending. Not stock question. I think KMC should never be undermined. When you are actually presenting these kind of cases. And please be aware of all the advantage of kangaroo mother care. And so if there is one answer, one of my a teacher would say that to improve neonatal outcome, if there is one intervention which you can do, is kangaroo mother care. Okay, so it's quite disappointing to see it at thermoregulation, because KMC probably needs to be emphasized more. All right, and the fact that it decreases not only sepsis, it decreases mortality. I think the emphasis should be more on kangaroo mother care. And here also, Dr. Shweta, I would want you to answer about the evidences what we have. So we have Cochrane's there, which actually specifies what morbidities and how much mortality it decreases when it is given, and also all the other benefits. So the developmental supportive care and also the exclusive breastfeeding rates is one of them. Okay, so I would want you to elaborate more in that term. So evidence based as well as all the other advantages, including the physiological benefits. Okay, so can you tell me what you mean by immediate KMC? Have you heard of this concept called immediate KMC? Did we lose Dr. Shweta?
Yes, sir, I think so, sir. She is, I think, logged out.
Yeah. Could the admin please check if she is available, Dr. Shweta?
She should rejoin. Let us wait.
We
lost her from the faculty list. I think she'll rejoin, I think.
Okay, sir. Okay, sir. We'll wait, sir.
Meanwhile, other participants, if anyone is, they want to answer, they can answer, because there are too many other participants who are logged on. They want to answer, they can answer.
So, audience, what is IKMC, immediate KMC, like sir asked?
I hope the participants can unmute and answer, I guess.
Yeah, participants cannot answer because they are muted.
I see some raised hands in the attendees. I think the admins can unmute them, I guess.
Sorry, sir, I got disconnected.
Okay, we're back. So, sir is asking what is IKMC, immediate KMC?
Sir, IKMC is started immediately after birth on babies who are on non-invasive mode of ventilation, and
So
there
who
was
are the candidates? Sorry, who are the candidates for IKMC?
sir, preterm babies less than 34 weeks of gestation who are either maintaining.
Isn't it low birth weight babies?
Sir, I'm not sure about the weight cutoff. Low birth weight also can be included, but
I think the participants can actually type in their answers. Go ahead, Dr. Shweta. Sorry. Yeah, all right. See, immediate KMC is something which I think is been endorsed by WHO, and all of us should know about it. I know there could be some barriers in our units where we won't be we will not be able to do it, but I think we should go to that at some point of time at least, and I'm sure all of us will go to that. Please look at the definitions of IKMC. And Dr. Shweta, would you know the new definition or the new endorsement of WHO on the definition of kangaroo mother care? So should kangaroo mother care be given to only stable babies, like you said, or can we give kangaroo mother care for even sick babies?
Sir, sick babies also we can give until or unless they should not be hemodynamically unstable or requiring immediate intervention. Otherwise, any baby on CPAP, NIMB can be started on KMC, sir.
Can you give KMC for an intubated baby?
Not for intubated.
We can.
No.
We can give. I mean, of course, some hemodynamic stability can be achieved. Even during kangaroo mother care, and WHO has broadened the definition of the duration of kangaroo mother care now. So please be aware of it. Please look at the WHO recent recommendations. Okay, yeah, please go ahead. I think so. Regarding nutrition, so when you start your nutrition, can you just get back to your previous slide?
Yes, sir.
Yes.
Yeah. Could you please? I mean, it's actually wonderful to see this. So, can you tell us what are the advantages of starting enteral feeds in a baby early?
Sir, usually if baby is preterm, we start with minimal enteral nutrition, which helps to improve gut motility, increase gut hormones, and reduces the risk of NEC. And it should be started with mother's own milk, or if not available, donor milk at 10 to 20 ml per kg per day.
All right. So, let's say for some reason we are not able to start feeds for this baby for some surgical reason. Let's say. So, what else we can do with the mother's milk?
We can do colostrum painting.
Very good. Wonderful. So, oral colostrum painting should be started in case we are not able to feed at all. All right.
Yeah.
Good.
So, Dr. Shweta, I have one more question. What is early total enteral nutrition?
Sorry, sir. Early
Total enteral nutrition.
Sir, to start early with to start early and progress aggressively with tube feeds in preterm babies to reach full feeds.
So it's a new concept, early total enteral nutrition. So in more than 26-weeker babies,
Yes, sir.
if they are stable, on day one itself, we can start with 80 ml per kg feed. Okay.
Okay, sir.
That is early total enteral nutrition. You should read about it. Okay.
Okay, sir. The baby is receiving calories of 161 kilocalorie per kg per day, protein 3.8 gram per kg per day, calcium 180 mg per kg per day, phosphorus 96 mg per kg per day, iron 3 mg per kg per day, and vitamin D 835 international unit per kg per day, which is adequate for the baby. Then metabolic for osteopenia of prematurity, routine investigation done on day 21 of life. One second. Revealed low phosphorus levels and high ALP levels. Baby is currently on vitamin D, calcium, and phosphate supplementation. Hyperbilirubinemia. Baby received phototherapy for 24 hours on day 4 of life in view of serum bilirubin in phototherapy range.
What are the cutoff values for the, like, to call it as mineral bone disease in preterm babies? You said no high ALP.
Sir, the cut if it is sir, for definitive it is now more than 900 and phosphorus less than 5.6. But if it
Okay.
is it is more than 500, it is indicative of low bone mineralization.
Mhm. So which like among calcium, phosphate, and ALP, which one has like more sensitivity in the diagnosis of mineral bone disease?
Sir, phosphate levels.
Okay, good. Okay. So the phosphate value was 3.8 and ALP was 682. So you started the baby on vitamin D, calcium, and phosphorus supplementation. When will you repeat
So usually
calcium phosphate?
after 2 weeks, we have to repeat and see.
You have to maximize the supplementation, then
Yes.
you will repeat it. And suppose the again the phosphate is, let's say, 4.6. What will you do next?
Sir, we will we can optimize the phosphate and we will continue the supplement for
Like
more.
how much calcium? Like what is the dose?
Sir,
Up to-
phosphate up to 100, 115 we can go, sir.
Good. Okay.
Yes. Regarding immunization, baby received hepatitis B at birth, BCG and OPV given on 9th September, and Hexazim, Prevnar, Rotatec were given on 10th September. So baby has been immunized for age. Regarding screening, extended newborn screening done was normal. Baby was screened for retinopathy of prematurity. Last follow-up was done on 10th September, which showed zone 2 vessels present with no ROP. Red reflex was present. Neurosonogram was done on day 1, 3, 8, and 28, which were normal. For osteopenia of prematurity, baby was screened and is currently on vitamin D, calcium, and phosphate supplementation. Hearing screen was done on 12th September, which was normal. Sir, can I go to examination part?
Could you just summarize your history part, please?
Sir, a preterm baby with preterm baby 28 plus 1 weeks with 1.2 kg weight with the history of PROM for 18 hours, born by LSCS. Baby had respiratory distress syndrome for which baby has received surfactant. Baby has been on full suck feeds with adequate nutrition, and all the screening till date have been done for the baby.
All right, go ahead.
Examination part, baby was examined in supine position with flexion at upper limb and lower limb, hip and knee at flexion. Baby was covered with one layer of clothing. Baby was active at the time of examination with pressure score 4. Currently in room air with pulse oximeter attached in right upper limb with SpO2 of 96%, with no episodes of bradycardia or desaturation during examination. Vitals: temperature 36.8 degrees Celsius in axilla, heart rate 145 per minute, pulses of good volume, respiratory rate 48 per minute, saturation 96% in room air, BP 60 by 42 with a MAP of 48, which is between 50 to 98th centile, and CRT less than 3 seconds. Anthropometry. At birth, baby's weight was 1.2 kg, length 38 centimeter, and head circumference 27 centimeter, which is between 50th to 90th centile. Present at 34 plus 6 week, baby's weight is 2.34 kg, which is between 50th to 90th centile. Length is 45 centimeter, which is between 10 to 50th centile, and head circumference is 32 centimeter, which is at 50th centile, according to intergrowth charts. Coming to head to toe examination, baby color is pink. There is no pallor or icterus. Anterior fontanelle is open with 2.5 by 2.8 centimeter at level pulsatile. Sutures are open. No facial dysmorphism. Skull normal in shape. Eye, ear, and oral cavity examination was normal. Umbilical system was healthy. Anus patent. Genitalia is female external genitalia. Hip examination is normal. Eye, extremity, and back and spine examination was normal. Then respiratory system, the respiratory rate 46.
Can I just interrupt here? So just go back. So I was waiting for the slide to come up. So you're talking about head-to-toe examination.
Yes, sir.
If you were to be examining this baby at 34 weeks, focused examination of this baby, general physical examination. So, what are the important things you would want to definitely see? Let's say you're there and your junior is examining the baby before discharge.
Yes.
What are the things he or she should be able to examine and tell you? Because they're not going to do it very, explicitly.
Sir, we should see if any pallor is present
Very
to
good. Yes.
anemia, and any eye discharge to be ruled out.
Any particular reason why a 34-weeker is predisposed to IDs? Nothing specific, right? It can happen to anybody. So I'm talking about a growing preterm who
Yes, sir.
probably is going to get discharged in a while, and you want your junior to focus on this examination. One is color, very good. So what else? Anything you would be looking at which this baby might develop now?
Sir, I can't think of anything.
Okay, so I think most of it is there. So I was looking at hernial orifices.
Yeah, yes, sir.
All right, so hernia is something which you will be looking at.
Hmm.
And in general, it's always good to comment on the general build of the baby. In the sense, I know that your baby has done well in, you're looking at your anthropometry. If there are any features of, growth restriction, extra-uterine growth restrictions also could be commented here.
Yes.
Okay,
Yes, sir.
sure. Go ahead, please.
Respiratory system, respiratory rate 46 per minute with no retraction. Chest is symmetrical with the bilateral air entry present and clear. Cardiovascular system, S1, S2 present with no murmur. Abdominal examination, umbilicus is healthy, abdomen is soft with no organomegaly and bowel sounds are heard. Central nervous system examination, higher mental function, Prechel stage 4. Cry and habituation normal, baby is moving all limbs equally. Cranial nerve examination, cranial nerve 2, pupillary reaction to light is present. There is no, for cranial nerve 3rd, 4th, and 6th, there is no nystagmus or ptosis. For cranial nerve 5, rooting reflex is present. Cranial nerve 5 and 7, there is no facial asymmetry. Cranial nerve 8, baby is showing blink and startle reflex to sound. Cranial nerve 9 and 10, there is no nasal regurgitation of feed, and baby is having good sucking and swallowing reflex. Coming to motor, baby's upper limb is at flexion and lower limb shows flexion at hip and knee joint. Bilaterally symmetrical movement of all limbs are present. Passive tone was tested. Scarf sign is at midline. Square window is 30 degree and popliteal angle is 120 degree. Active tone is also corresponding to gestation. Deep tendon reflex present. In neonatal reflexes, rooting and sucking reflex present. Moro is bilaterally symmetrical, incomplete, and palmar grasp is present.
Just a comment, just go back. We don't expect you to do a Moros, especially in a preterm baby. You could conveniently skip this. Okay, so this we keep often seeing.
Okay.
So can you tell me what are the problems with Moros? Okay, let us discuss a little bit so that we'll remember it. So what are the problems you anticipate with the Moros reflex for a preterm baby? Potential problems.
Sir, Moros will not be completely elicited. And
Okay, obviously that is one. Okay, so it might not give you the full picture, the intention of for which you're looking at. It might not. It's satisfied. All right. Yeah. What else?
and for very preterm baby, the movement we do for Moros is not like should not be done.
So we have. So if you're doing Moros for the tone and movement, you have other ways to do it, isn't it? So Moros may not be required. But I'm asking about what are the problems with Moros?
Mm. Not
Do you
sure,
want the
sir.
baby to cry? What happens after the Moros is done?
Sorry, sir.
What happens at the end result of a Morose reflex?
Sir, like in end at end the baby will do flexion and adduction with the cry.
Yes, yeah. So the last part, do you want a baby to cry?
No.
No, we don't want the baby to cry, okay? Please be very gentle in your exam. So the reason why I'm asking, I mean, telling you is because one of the things which examiners keep looking at, and I mean, not just exam, not for exam. So when we are examining a baby, we should make sure that it is with utmost, care, and make sure it is comfortable thing for a baby. We don't want the baby to be uncomfortable when we are to examine the baby. Obviously, we don't want the baby to cry. Okay.
Yes,
In
sir.
fact, we will see how well you examine a baby without making baby cry, or if the baby is crying, we'll see how you console the baby. Okay, so please don't do monos. One is cry. We don't want crying babies in NICU. Second thing is, cry increases your energy expenditure.
Yes,
And in preterm babies, if there is a lot of posture movement, sudden posture movement, what probably can potentially it lead to?
sir. IVH risk.
Yeah, so I mean, not so
Hmm.
much for a 34-weeker. Okay,
Hmm.
so especially in the first few days, it might be a risk factor for your IVH. So those are the things which we don't want to do. Okay, sure.
Yes. Yes, sir. Coming to diagnosis, very preterm, 28 plus 1 week, appropriate for gestation, very low birth weight, 1.2 kg, respiratory distress syndrome with osteopenia of prematurity and neonatal hyperbilirubinemia with current gestation age of 34 plus 6 week, day of life 47 and current weight of 2.34 kg with adequate weight gain and adequate nutrition.
Yeah, so
So,
do you want to discharge this
Dr.
baby? Yeah, Dr. Vijay, please go ahead.
you want to you should have taken the decision to discharge this baby, let's say at 34 plus 6. So what all parameters you will look at? Discharge preparedness in a preterm baby.
Sir, discharge criteria, first is gestation should be 33 to 34 weeks with the weight of 1.4
to
to 1
34.
point. Sorry, sir.
So you want to give
Our
caffeine till what gestation?
caffeine till 34 weeks we give, sir. This baby already we had.
That only want to discharge the baby.
Sorry, sir.
So you said no 33 to 34 I will discharge the baby. So
Like this is
on
our
caffeine you want to discharge. So
our
in
unit.
general only I'm asking what is the criteria to discharge a preterm baby? Criterias to discharge a
Sir,
preterm baby.
baby should have
In
adequate
preterm.
weight gain of more than 15 to
Yeah.
20 gram per kg per day for 3 consecutive days, and baby should be on
Okay, good.
pallidi feeds or suck feeds, and parents should be confident in giving the feed to the baby. Baby should be able to maintain the temperature in open cot. Baby should
Okay,
be
good.
off caffeine for 5 days, and acute illness should be treated, and the baby should have all the screening till date and immunization till date completed, and
Good.
mother should be or caregiver should be trained and confident in handling the baby, giving KMC feeding, and they should be told about regarding the follow up, and they should be also told about the supplementation and immediate resuscitation if required, and baby should
And
be
vaccination.
for high risk clinic.
Yes, yes. Vaccination as well. Okay.
Yes, sir,
Baby
immunization.
should be vaccinated. So specific to this premature baby, what other vaccine you will like to give?
Sir, we can give RSV vaccination for preterm baby. Palivizumab is available, or nirsevimab is also available.
Is it for treatment or prevention?
Sir,
This
prevention of
nirsevimab.
RSV.
Good. One more question I have regarding caffeine.
Yes, sir.
So what are the indications to give caffeine in preterm babies?
Sir, usually less than 33 weeks we are giving caffeine, and if baby.
What is the indication? Like, why do you want to give caffeine in a preterm baby? So what are the indications to give caffeine?
Sir, first is any preterm with the respiratory distress or in respiratory support, less than 34 weeks will start. or if less than 32 to 33
So
weeks.
in extreme preterm babies, we
For
start with caffeine on day 1 to
prevent
prevent
apnea of
apnea
prematurity.
prematurity, which will in turn reduce the burden of BPD. One is that. Okay.
Yes, sir.
Second one is for the treatment of apnea prematurity. So any less than 34-weeker baby who is having apnea, so we start with caffeine. So there the indication is treatment of apnea.
Yes, sir.
The third one is to facilitate extubation in preterm babies.
Yes,
So these
sir.
are the 3 indications.
Okay, sir.
Prashant sir, you want to ask anything?
No, nothing much. So, do you think this baby could be? Can you tell me the discharge criteria which you follow in your unit?
Sir, regarding gestation, 33 to 34 weeks of age and weight of around like more than 1.4 kg. And rest regarding weight gain, I already told all other criteria.
You want to discharge a baby who is 33 weeker?
Sir, if baby is accepting feeds well for 3 consecutive days and baby is gaining weight correctly, then we can discharge.
33 weeks.
Most
At
34
33 weeks.
weeks. So 34 weeks.
So why probably you're looking at 34 weeks or even 35 weeks?
Sir, by 34 weeks, the baby's the suck swallow reflex is matured and the risk of apnea is also less. So mostly by this time babies gain weight and start taking pellidi or suck feeds also.
Yeah. So absolutely correct. So at 34 weeks, you have this coordination which starts, and the baby would be ready to directly breastfeed. And of course, it can happen much before also. It depends with individually between baby to baby. At least 34 weeks, we have to wait. So most of the units look at 35 weeks. When you say 34 to 30, 33 to 34 weeks, so it becomes very vague. So the point is, we might be, you should be knowing very clearly about the discharge policies of your hospital, at least, because that will have a basis. And most importantly, it helps you in counseling the parents.
Yes.
All right. And 1.4 again would be a little less. If so let's say you're discharging the baby at 1.4 kilos, which some of the units would still follow. What is one thing which you would ensure when you're discharging a baby with 1.4 kilos?
Sir,
Apart from what all you said.
Sir, feeding part will ensure.
Yeah, so you
parents'
told us about the
confidence.
growth, you told about the screenings, immunization, nutrition, everything. So what would you ensure if at all you are discharging a baby
Follow-up.
little early? Okay,
Correct.
early follow-up, yes. Provision for early follow-up, yes. Anything else? So you would ensure, kangaroo mother care. Again, kangaroo mother care comes here because
Yes.
one of the components of kangaroo mother care is early discharge and follow-up. Okay. So you need to ensure that adequately the mother is giving kangaroo mother care or at least 8 hours, and that is being practiced in hospital, which gets transited transited to the at home. So that's when you would do it. Otherwise, it will be a little challenging to discharge such a small baby. Okay.
Yes, sir.
So if you were to discharge the baby pretty early, so I was just wondering why you are examining the baby in your NICU even at 34 plus 6 and 2.3 kilos.
This baby, we were not able to establish that suck feeds. Baby took time to reach to take full suck feeds.
Sorry?
Sir, baby, it took time to establish the baby on suck feeds and direct feeds.
Direct feed. So would you give palliative feeds at your unit?
Sir, in our unit, we are giving not giving pellidi feeds. We are giving bottle feeds.
Okay. So what are some of the interventions which probably will help establishing direct feeds a little early?
Sir, one thing will be to start non-nutritive suckling
Very good.
early,
Yes. Hmm.
and other will be oromotor stimulation
Very good.
be started early.
Okay, so these are two things which will probably help the baby to achieve full enteral feeds orally. Okay, sure.
Yes.
All right. So, how do you give non-nutritive sucking? Since you have said that.
Sir, we can do it on empty breast, and we can initiate it early also, like at 28 weeks also we can initiate it.
Yes, very good. So that's a way to do non-nutritive sucking. So as soon as the baby is stabilized, irrespective, even the baby who's on HFNC, we can actually initiate non-nutritive sucking, on an
Yes.
empty breast. Good, wonderful. All right. Yeah. So and how will you follow up this baby?
Sir, first follow up will do at 3 to 7 days, and then later subsequent we will be following the baby in high risk clinic, and first follow up after 3 to 7 days, and then we can follow 2 weekly till the baby reaches 2.5 kg weight, and then further follow up can be at 3 months, 6 months, 9 month, 12 month, 18 month, and 2 year of age, along with neurodevelopmental follow up.
So at each visit of this baby, let's say in the first 1 month,
Yes,
what
sir.
all will you look at?
Sir, first thing we'll be seeing for feeding, and to ensure they are giving feeding, all the supplements. The other thing will be to look at anthropometric parameters, and we'll chart it according to the growth charts. Then next will be to follow up with the screenings, like follow up ROP screening, vision testing, then hearing screening follow up, any follow up ultrasounds if at term, or any pending ultrasound that is there. Then we'll be doing neurodevelopmental follow-up and neurological examinations.
So what would you do in your unit? What neurological examination you look at for the follow-up, following up these babies?
Sir, we can see Emily Tyson angles, and we can see Heinz.
Good. All right. Yeah, I think that's it from me. Anything else, Dr. Vijay?
So she talked about developmental supportive care. So Shweta,
Yes.
what are the components of developmental supportive care?
Sir, developmentally supportive care includes one will be the protected sleep for the baby. Then there is we have to provide healing environment to the baby, which will include uh, good tactile stimulation, and the voice levels of the NICU should be less than 45 decibels. The visual, there should not be excessive visual stimulation for the baby, and baby should be the visual stimulation should be the mother's face, and proper then there will be minimal handling and pain management for the baby, and
Good.
family centered care, and starting optimal nutrition, and encouraging breastfeeding, KMC, and protecting skin.
Yes, good.
Yeah, I think that was a good presentation, and most of the questions were answered. Well done, Dr. Shweta. So that was good. So even I appreciated the way you presented your examination as well. So as I said, few things which are kind of must knows, we should not fumble, especially when we are dealing with preterm babies. So please go through WHO recommendations and also NNFCPG guidelines. I think those should be the base for all the fellows, and then you get into the depths of your other things. Okay, so otherwise, I think it was very well presented, and thank you so much. So anybody else, Abhishek, you have any comments or questions?
Nothing, Prashant. I agree with you. Shweta did a good job in a very short period of time. I think it was well presented, and She handled both of your questions confidently.
Yes, sir.
And
Yes.
I think most of the questions were, I think you can see they were very simple, but in exam also the similar questions will be asked. So probably some of the questions you might be knowing the answers. Some of the things what you learned today probably you can become, or you can go back and read it so it becomes easy for your exams later. So I thank both our faculty, Dr. Vijay and Prashant, for facilitating today's session. So we thank NNF, and we'll get back again next week with a approach to upper newborn emergencies, case-based approach in newborns, from interesting case presentation from Rangatari Hospitals, Bangalore. We'll get back to you next Thursday. Until then, good night, all of you. Thank you. Giridhar sir, you want to say anything? Giridhar sir?
I think it'll be good if we enable the names. I think it'll be good for us to address. We don't know who is there if the camera is closed.
I think we've lost Giridhar sir. No problems. Thank you, everybody. Thank you, Prashant. Thank you, Vijay. Thank you,
Thank you,
Shweta.
sir. Thank you, sir.
Thanks, Abhishek. Thanks, everybody. Thanks, Shweta. That was a good presentation.
Thank you, sir.
Thank you, everyone,
Well done.
and well done, Dr. Shweta. Doctor.
Thank you, sir.
Good night. Take care. Bye.
See, it is not non-alignment. It is multi-alignment.